Hey guys, this is Module 2, and we're going to do it pretty briefly because there's no way, I know when you're looking at this right now, you're thinking what I thought. Oh my God, that looks complicated. I'm going to make it real easy for you. The first way I'm going to make it easy for you is, and maybe we ought to think about this for future courses, maybe you ought to go the extra mile and bring your surgical assistant with you, because that's who really needs to know this. You are managing the patient. You are managing the surgery. And I will tell you, my surgical assistant, Amber, and others that work here know way more about this than I do. But this is different than the surgical kit you saw in Module 1 because this is a guided surgical kit. So guess what? I didn't even need this for 18 of the 25 years I did implants because I didn't do guided. I don't know when guided came to be a thing, but it became a thing for me 5 to 7 years ago. And now in the Institute, when I bring you guys in, my goal is to have you know both, because you have to know both for reasons you're about to see. But you're going to do guided most of the time. And I want to really tell you one thing before I get into it. I used to think guided was for guys that didn't know a lot about surgery. And that's because I was taught at the Mish Institute in the 90s, freehand. That's all we ever did. We didn't even have a CBCT to do this. And I was wrong, because implants can fail for a multitude of reasons, not the least of which is you put them in at the wrong angle, even though you thought you put them in at the right angle. And learning to do guided absolutely makes you a better surgeon for when you do free-handed. And here's why. The workflow when you do a guided is you're going to send, unless you do these yourself, which I definitely would not recommend. I know I would be booed off the stage by a lot of guys who print their own guides and all these other things. Listen, let me tell you something. If you watch the Lionhearted podcast that I do every week, you will know that I am all about you having a life that extends beyond your office. And if you want that life, at least in my world, I want to spend as little time here as I can when I am finished. That is why the way that I do these things is, number one, I take my CBCT, and before I had my own CBCT, I sent them to, like you're going to have to various places to take the cone beam x-ray, and I paid for it. I paid whatever it was, $250, $300 at times. That's what you have to do in the beginning, and charge for that. When I'm doing an implant case, I charge $500 for the guide, which includes the cost of the cone beam x-ray. Okay. Then what you're going to do is, most of you have a scanner in your office. So obviously you're looking at a 3D analog model. I have a scanner. We just began to scan these models. But what I do is I send the model, this model, hard copy, overnight to, I use 3D Diagnostics. I've tried others. I do not have a problem you expanding out and trying 2 or 3 or 4 companies. I use 3D just like I use BioHorizons, because that's what I started with. And very often it's comfortable for us as clinicians to follow what we started unless we have complications. It's just the truth. So I send my x-ray, which I don't even do. I've delegated that. I take a model. The models have to be pristine. They can't be sloppy. They can't have bubbles. Okay, so now we're going to focus on, well, what's the guided experience like? Because the kits look similar, and they are. Here's the story. All these drills are very similar to the drills we use for the first module, the surgical kit. Here's the difference. They're longer. This first row is 17 millimeters. The second row is 21, 24, and then 28 millimeters long. Why? Because you have to have it longer to get through the guide to get to your osteotomy site. Does that make sense? If this was freehand, I don't need to have longer drills. It's guided. It has to go through a guide. That's why they're longer. That's why it's different. So you're going to need, if you're going to be an implant surgeon, you're going to need a regular surgical kit and a guided surgical kit. And I don't know the cost. I think they're every bit of $2,000 or a little more. So let me take it through real quick. So you're looking at right now a tooth-supported guide. Tooth-supported. It means I don't need a fixation pin. It is held in place by the teeth. It is as easy as it possibly can get. Now I got to give you a little principle of Steve Rasner at the Rasner Institute. I flap almost everything I do. And I place the actual implant without a guide. I want to see with my eyes the implant going down in the bone, and I want to see exactly where I'm at. And as you're going to see in the lecture I do before we work on patients in the next couple weeks, you're going to see when you come in that what I believe in is seeing what you're doing. There are times, today I did an implant on number 7. It had abundant attached gingiva. I did the extraction and the graft. I had a beautiful PA and CT. I knew what this site looked like. And that is not often, but it was today. So yeah, I punched. It's always better to not flap in terms of healing, in terms of tissue shrinkage, of course. But it has not been a major drawback in my surgeries or yours, in my past history. So this patient's going to be flapped from at least one tooth posterior, possibly 2, a sulcular flap, probably no vertical releasing incision, up to the anterior tooth, which is a cuspid, and the palate. So you're flapped. It's not a big flap. And then you put your tooth-supported guide on. And I make that distinction to you because, as you're going to see in the next module, there are bone-supported guides, which are much more challenging. And you're going to do both at the Institute, which you need to do. Okay, so now that you have that in place, what's going to happen is your dental assistant is going to hand you the ring system. Each one of these rings, that's what you're looking at here, a bevy of different rings because they're all indicated for a different diameter. Do you remember in the prior module when we did a 2.0 and then we did a 2.2 and then we did a 2.5? Well, each one of those drills needs a different ring, and that's what these are. And I'm telling you, although it may seem complicated, it's flawlessly done by your dental assistant. I don't know if I've ever, maybe a couple times, I don't remember, reached in, put the ring inside the hole. I mean, it only goes one way. And then your drill goes, obviously, inside the ring. So you have a drill in your hand, and your implant drill, and your dental assistant's holding this. And of course you want to make sure, I even use a third assistant sometimes, that it does not wobble whatsoever. This has to be totally stable, and it will be. It'll be totally stable. That's why your company, my company's 3D Diagnostics, will insist on pristine models. And if you scan it, how can you mess it up anyway? And that's it. It's the same sequence that you would follow with freehand, except you're using a guided kit because the drills have to be longer obviously, to get through the guide and get to the bone. And every other aspect of the kit is similar. So when I'm doing guided, which we're going to do 75% of that's going to be guided, I'll have both kits out. Because for me, when I get through all the osteotomy drills, I'm going to take the guide off at that point. You don't have to. You can actually place the implant through the guide. But I don't see the point of it. I take the guide off. It's flapped, remember. All I'm placing is an implant. My last, the last part of my procedure, and I'm watching it go down to the level that I want it at. If it stops above the crest, I'll go to the ratchet and I'll ratchet it in freehand. I love doing it. You're going to like doing it that way because it gives you the confidence that you're exactly where you need to be. I didn't tell you this. I want to finish with this. I left this out. Whenever you do guided, there's going to be a session between you and the company that you're paying. And at that session, the way that I do it is they pipe into my computer. So we're sharing the screen. And I'm looking at the CBCT with them. And we're looking at, well, is there any problems in this planned surgery? They can tell you if the bone density is poor. And hence you'll use something called Versa drills, which I'm sure you've heard of. You're going to use those at the Institute. You won't use these. You'll use a different drill called a Versa drill. They'll tell you if you have to expect grafting on the buccal or the palatal. It is so superior for no other reason. I mean guided. Because it prepares you. Even if you didn't do it guided, but just had this session, you're going to be in a superior position for a superior outcome. So look forward to seeing you guys in a couple weeks. Let's do this.